This talk today is on sepsis. It's really a very, very straightforward one. And I could probably give you the high points in 2 minutes, but it's probably worth spending a little time going over what happened. So how many of you are still following some rigid sepsis guideline? Not that many, good. Okay, the rest of you got to do something about this. So what's new in the world of sepsis? Well, as you know, a couple of things happened 10, 15 years ago. One of the things that happened was that the powers that be, the so-called experts in the area, decided that sepsis was too ill-defined a concept and they had to define it objectively and reproducibly. So they made up these new categories called SIRS, Systemic Inflammatory Response Syndrome, and then sepsis and severe sepsis and septic shock. And I only mention that because I think it's, what they did is a real disservice to us. So let's go back 20 years ago. When you said, how about today? If you say, I got a patient, he's septic, what do you mean by that? It means he's sick, right? I mean, there's some utility to that word. You're trying to express a feeling you have about this patient. This guy's not just got an infection, he's septic. If you look at the criteria for sepsis, according to the guidelines, virtually everybody who has a strep throat is septic. Because all you got to do is have a heart rate of 90 and a fever. Not to mention silly, non-specific labs like CRPs and SED rates, which have no value at all for anything, but now are included in the definition of this. I find that objectionable. I understand the desire to make us all be talking exactly the same words, but language matters, you know, and language has utility. And so I don't understand this. I think it's a little bit crazy, but that's just me. Okay, now let's go on to the other big thing that happened is article number 1. Article number 1 is the famous paper about early goal-directed therapy by Manny Rivers and company from Michigan and Henry Ford. And what they did was they said, you know, for years we've been treating sepsis for bad sepsis, septic shock, sick patients. We've been treating them and getting the same lousy results. A lot of them die, and it's time to do better. So they came up with a series of things that you're supposed to do together in a protocol that they tested and then told us changes the whole world. And how did it change the world? Made mortality tremendously better, with a number needed to treat of 6. Now, to put this into perspective, when antibiotics came along for sepsis, they didn't decrease mortality by that much. Sepsis, when somebody's really septic and in shock, they're doing really poorly, and a lot of them go on to die. And even the introduction of antibiotics didn't change that greatly. And along comes this protocol that was fabulous. So there are several possibilities, explanations, right? One explanation is it's wrong. They got it wrong. They measured it, it looked good, but it really wasn't good. And at the time, there were all sorts of rumors about, you know, was it really true? And some people from the area said, you know, I don't think the numbers really showed that. But what they reported was really remarkable. So too good to be true, you should always be a little bit concerned. Second thing is, and it's a small study, 250 patients, a little more than 250 patients. So some of us were a little skeptical for that reason. The second thing was there was a whole bundle involved, right? What did the bundle include? Well, it doesn't really important to go over all the details, but they included early antibiotics. That sounds like a good idea. That might work. 2, lots of fluids, aggressive fluids. Well, that's been shown over and over and over again to be really important in bad infectious disease, that people get vasodilated and hypotensive, and fluids are the only thing, as far as I know, that's ever been shown to increase mortality in shock, period. That's not entirely true. In anaphylactic shock, epinephrine works. But if you think about shock, we're always talking about what's the different types of shock and what do you, but it turns out that the only thing that actually has a direct effect on mortality is fluids. Billy mentioned yesterday something I've been saying for a long, long, long time. There's no evidence anywhere that pressors increase survival in anything. In heart attacks, in cardiac arrest, in sepsis, etc. They do a lot of studies comparing one pressor with another, but they never compare them to nothing. And the only places where we've done that is like high dose of pressors versus low dose. Low dose is always better. I always ask, how about really low dose, like 0 milligrams, and see how well they do. And you remember cardiac arrest, high dose epi. Did everything good except the patient died. And that's one of the problems with pressors is that they always benefit the surrogate outcome, which is the blood pressure, but the patient goes on to die. And there's lots of physiologic reasons why you would imagine that that would be true. And that's not to say it's been proven that pressors are useless, but it's certainly not been proven that they're helpful. Anyway, so fluids, antibiotics, that sounds good. A third thing not mentioned in there is pay attention. I've mentioned many, many, many times that studies of whatever medical topic you want show that when we pay attention to it, when we make a special unit for that disease or a special protocol for that disease, outcomes are better. That's been shown for COPD. If you're on a COPD ward, you survive better. If you're on a heart failure ward, you survive better. If you're on a diabetes ward, you survive better. If you're on a stroke ward, you survive better. And then when they dig down into what that is, they can never find a medical reason for it. And it doesn't even matter who is on that ward. So stroke is my favorite example, where if you're on a stroke ward, you get much better outcomes in a stroke unit. But that's true independent of whether or not they have a neurologist there or a stroke neurologist there. And it's independent of any treatment except for nursing care. What really matters is that they slap on your back and don't let you aspirate and put the head of the bed up and give you Tylenol if you have a fever, because fever is bad. That's it. So paying attention matters, and that might be another part of this bundle that really is useful. Then there were some other things that I don't really want to go into, except that they don't make a lot of physiologic sense. They measured all sorts of things, like lactates, and they did them in a really special way, like in the central venous measurement, central venous oxygen saturation. And then they were very aggressive about other things like pressors and blood. Now, all of those other things, beyond the first 2.5, 2 and attention, don't make any sense. And there's a wonderful editorial here before the big studies came out, number 6 by Marique, which says early goal-directed therapy on terminal life support, which goes over all the reasons why none of these make sense. And I'll just remind you that central venous oxygen saturation, for example, and CVPs, and basing things on that sounded really weird, because it was just at this time that the big studies came in that were showing that Swanganz catheterization did not lead to improved outcome in ICU patients. It actually led to worse outcomes. The reason we had a Swanganz catheter, when I started, I was going to go into medicine and I was going to go into cardiology, and my teacher was Willie Gans, so we put in a lot of Swanganz catheters. And I bought it. I thought, this is great. And the reason I thought it was great was because it made so much more sense than a CVP. And you all probably learned in medical school why CVP is no good, and Swan really tells you what you need to know. And the studies which ultimately showed that Swan didn't work showed that it wasn't because we misused it, it was because we followed its instructions. We did everything the Swan told us to do. The physiology was great, everything was perfect, except it didn't work. It didn't cause benefit, and it ultimately caused harm, because when you put in a lot of central lines, you cause harm. And the amount of harm was just about the same as the amount of central line harm that there was. So it wasn't that the Swan made you worse, it was that putting it in made you worse, and it didn't do anything for the good. So how could it be that the poor man's terrible version of a Swan, a CVP, was going to make it better? Didn't make a lot of sense. So another possibility was that some aspects of this did work. That was why it was so good, although so good seemed a little strange. Or, but that the other things didn't, and that the whole bundle wasn't what was necessary. Then there was this other little bit of niggling doubt that had to do with the fact that you were supposed to do the entire bundle, that a drug company, which was selling a drug called Ziggurats, you all remember Ziggurats, $100,000 a dose, they were selling this, put on this Surviving Sepsis campaign, which was all about early goal-directed therapy and Ziggurats. So this was supported by a lot of money. That's always raised a little antenna on me. And another part of it was that the people who wrote the paper owned the patent to the catheter that you were supposed to use in the central vein. It wasn't just any old CVP line. You had to use a special catheter that measured this oxygen saturation, and they owned the patent. And that was like, ooh. So anyway, I was pretty skeptical right from the start, and as others were, and I thought maybe it is good to pay attention and probably good to use antibiotics early and be aware that this is a life-threatening disease and give fluids early, but I didn't believe the other stuff. So two groups, one in America, North America, including Canada, and one in Australia. The first organized something called the Process trial, and the second organized this thing called the ARISE study. And both of them said, they announced, we're going to retest this. This is so great, let's retest it. Oh, before I get to that, let me just say that with Ziggurats, you know, one of the really nice parts of the Surviving Sepsis campaign was that Eli Lilly created this group of expert ethicists. And as part of the Surviving Sepsis campaign, they published documents which asked the question, was it ethical to withhold life-saving treatment just because it cost $100,000 a dose? That was the ethical question. Now, what they forgot to mention was that their drug met one of those two criteria, but not the other. It did cost $100,000 a dose. It wasn't life-saving. In fact, we no longer have Ziggurats around because finally, after the original studies telling us how great it was shown that it didn't do anything good and actually caused lots of harm. So is it ethical to use a drug that costs $100,000 and kills people? That's probably a little different question. But I always thought it very interesting that these ethicists were on the payroll. But anyway, so along came the announcement that they were going to restudy this, and the response of these authors was really chilling. They, you know, in my mind, the biggest honor you can get as a researcher is somebody wants to try to replicate your work. It shows they're serious. We believe, oh, that was really good work. It needs to be replicated. The response of these authors was scathingly negative, that this was, that they were being defamed and worse. I'm not going to get into it, but they really said anybody who tries to reproduce our work is lying, and they're calling us names and doing bad things, which is sort of crazy. They did one study, 260 patients, the best thing ever. Sure, repeat it. Let's see if it works. So the big news is the last two is the two big studies, number 11 and number 12. Together they had about over 2,100 patients. That is almost 10 times as many patients as the original study from Henry Ford. And what did they find? Well, guess. Patients were randomized into standard care versus you had to follow this protocol. And in one group, in the Process study, they had a third group, which was you had to follow early antibiotics and IV fluids, but you didn't have to do the rest of it. And all of that, basically, they found no difference in any groups. None. Not a number needed to treat of 6, a number needed to treat of infinite. In fact, of course, there was slightly more harm in the protocol group because of putting in the lines. I wasn't surprised by this. What I am surprised by, you know, there's a big thing about how long it takes us to incorporate new medical information. So somebody comes up with some fabulous thing, and it takes us 10 years to actually put it into practice. But you would think that getting rid of bad stuff wouldn't take so long. And you would especially think that guidelines would say, ooh, okay. But the ID Society guidelines, after these were published, reinforced that you must do early goal-directed therapy. So there's one paper, questionable for a lot of reasons, published on 260 patients that said it was magnificent. Two huge, well, beautifully done, randomized, multi-center studies, which showed that it's not true. And the ID Society said, we must do it. I don't know how to explain that. I mean, I do know how to explain it, but I'll let you think about it. that's basically this chapter. There's one other thing to say, and I just want to, a couple other things to say. There's less is more. So there's an article, number 13, which is about you don't need to get the blood pressure that high. We talked about this yesterday. There's got to be some blood pressure that isn't good. It's too low, which you'd like to get it higher than. Although just because it's really bad low doesn't mean that making it higher makes it better, right? So let me give you an example. When you have a perfed appendix, you tend to have a very high white count. But that doesn't mean that if we did plasmapheresis as the treatment, you'd do better. Lowering the white count it may be a marker of you're really, really sick, but it may not mean that fixing it's going to make it better. And this is a problem that we have in medicine all the time. We look at things that are markers of disease and we say, let's fix them. But fixing them doesn't work. Same with cholesterol. Cholesterol is, we did a thing on this a few years ago about surrogate markers. There's no evidence anywhere, zero, no evidence, good evidence to the contrary, that unless you have one of the familial hypercholesterolemias with sky-high cholesterol, where it is useful to lower the cholesterol, other than that, cholesterol is associated with bad outcomes. Fixing it doesn't help. Same is true, certainly true for blood sugar in type 2 diabetes. High blood sugar is bad. Lowering it doesn't work. So there's got to be some number where it's bad, it's too low. If we're going to shoot for a target with fluids, we're not sure what that target is. It's probably not normal blood pressure. You don't have to shoot for normal. You probably have to shoot for enough to perfuse vital organs. How much is that? I don't know. Nobody knows. But this article says lower is better than very high. And the same was true for the last article, which is about blood. If you're really, really anemic, that's probably not a good idea. But you shouldn't shoot for normal hematocrit. You should shoot for low. Should you shoot for lower than low? Maybe. Nobody's tested. Nobody knows where's the lowest. We do know with anemia, by the way, that acutely you don't need oxygen carrying capacity. You need fluid. You need circulation. So people can survive for certainly in the short term, hemoglobins of 2 and 1. That's probably not good for you, but you can survive that. Resuscitation is fluids, not the other. And there's one article in here also I'll just mention before I get to the last topic, one article which says, maybe Ringer's lactate is better than normal saline. Now, I have a principle that I use, which is anytime the same question has been studied more than 700 million times, it cannot matter what the answer is. Because if it really did matter, we would know by now. We wouldn't need 700 million. So there's been a million little studies that say, oh, Ringer's is physiologically better, and other studies that say, we compared the two and there's no difference. Same is true for head of starch and albumin and all sorts of other fluid substitutes. As far as I'm concerned, it should be now pretty clear that normal saline is the right fluid. And not half normal saline and not extra normal saline. If you're too osmotic, the way to get back to normal is gently with normal saline. If you're hypoosmotic, the way to get back to normal is gently with normal saline. There are only very few conditions where you might want to do differently. Very, very few, and they're dangerous. So like you're seizing with a sodium of 102, yes, you use hypertonic sodium, but that's it. Anyway, that's a different topic. One last thing, there are two articles in here which said, maybe lactate clearance is what we should be measuring, not just lactates. Now, I will point out to you that there's no evidence that measuring lactate or lactate clearance actually improves anything. The reason that these two articles say do lactate clearance is because when they looked at outcomes, the patients who died did worse in terms of their lactate clearance than the patients who didn't die. Whereas the patient's lactate didn't really predict very well. But again, this is what I've just been saying all along. Just because A and B are associated doesn't mean you can use it in any way that would change your management in a useful way. Yes, lactate clearance seems to be a marker of who's very sick. The people who are really sick don't clear their lactate very well. Okay, now take care of them. Weren't you already doing everything you're supposed to do? What are we going to do different? We're going to go in there and suck out the lactate, dialyze the lactate? I mean, I don't know what that's supposed to mean. So just be careful of these studies. We talked earlier at the beginning, the first lecture was be skeptical when you read. One of the big problems is people are always measuring the wrong thing. Yes, lactate clearance is a marker of sickness. No, that has no meaning whatsoever in terms of should you do anything about it, or should you measure it. Now, I know that I'm a sort of a minimalist about tests, and tests are good when they actually change what you do, give you information you wouldn't otherwise have that you could use. But I'm pretty skeptical about people telling me to order all sorts of things that I have no idea how to use. And most of the time when you do it, you're going to also create problems for yourself. Confusion, interventions that are harmful, not necessary, etc. So I just want to point that out. So, any comments, thoughts, questions? How are we going to get out of this conundrum? Okay, I'll make an appeal to you. I may have said this earlier. Either that or I said it in the course I did last week. I'm doing 2 courses back to back. And so I don't remember what I said. But if I didn't say it, good. And if I did say it, so be it. I'll reinforce it. Last year, ACEP, a year and a half ago, ACEP, after years of holding the fort, approved a new guideline which said we should use TPA for stroke. And they announced this, and it was a shared guideline with the American Academy of Neurology. And every study that's been done, and there have been a bunch of them, asking emergency physicians, what do you think, shows that most emergency physicians think this is not proven. It's not a proven therapy. They range from people like me who think it's pretty close to proven harm, to people who say simply it's not proven. And technically, I think that's the right answer. It's not proven one way or the other. There's not enough information to say for sure. But to say it's a level 1 class A thing that we need to use it's going to mean all of us are going to get in trouble when we don't use it, seemed like a really bad idea, I thought. So when that happened, many people wrote me letters, because I'm pretty vocal about this, and wrote me emails and said, what are you doing about this? And I said, what do you mean, what am I doing about it? What are you doing about it? And fortunately, we as a group, emergency physicians, did come together. A lot of people got together, and a couple of state chapters wrote a resolution saying this is a bad idea, shouldn't have been done, this is wrong. And they presented it at the ACEP National Scientific Assembly last year in the council, and the counselors, remarkably, voted 3-to-1 to tell the board to rescind the policy. 75%. That was amazing. They'd never before told the board to rescind the policy. They came close with the Choosing Wisely campaign, where they just lost out on a resolution to tell the board we should be part of it. But this was 3-to-1. So that was pretty neat, but I didn't think anything would happen of it. But remarkably, the board agreed to reconsider, and they opened it up for public comment. And I don't know what the public comment was, because I don't have access to it, but I was told by somebody who does have access to it that supporters of the policy said it wasn't fair because it was, the public comment was 100% against, and therefore it couldn't be reliable. I don't know if that's true, that's what I was told. Anyway, then remarkably, after this period of public comment, the board, I thought the board was going to say, oh, we considered what everybody wanted, but you know, science is science, and the science is that it's good, and we stand by the policy. But they didn't. They said, you know what? We're going to reconsider. And they opened it up, and they said, we're going to appoint a new committee, and this time we'll have a revolutionary rule for the committee, which is you can't be taking money from the manufacturer, which they had never done before. And you should know that guidelines from medical organizations, especially specialty societies, are almost all full of people who are taking money from the manufacturer. And when I say that, I'm not exaggerating. More than 3/4 of people who sit on guideline panels are taking money about something that they're writing about. And more than 90% of panel chairmen are taking money. So this idea of you can't take the money and be on the panel was a little revolutionary. It's something that I and others had proposed in an editorial in the British Medical Journal, and they followed it. And then supporters said, this is outrageous, science is science, you know, who cares what emergency physicians think? It's proven to work. But it turned out when the new panel came on, which didn't have ties to the manufacturer, science wasn't science. And the new policy that they have prepared and is now open for public comment says, no, it's not proven. So the only thing that's proven about TPA for stroke is that it causes harm. That's the only thing that's proven for sure. Whether it also causes benefit, unclear. I don't think they have finalized that policy. It's open for comment now. But the reason I tell you all of this is because I think it shows something really important that I keep trying to say, which is that individually none of us are important. But together we actually have a voice. So this craziness about EGDT, and you have to follow it and you get dinged if you don't, you have to put in central lines when you're busy with other patients, and that's a bad deal. And it's bad for this patient as well. We shouldn't stand for that. We should say, no, that's wrong. It's proven wrong. We're not going to do it. We need to fix it. So we is the operative word.